Hi, welcome to the Jewish Orthodox Women's Medical Association podcast. I'm your host, Elisa Minkin. I'm a pediatrician and I am the chair of the Preventative Health Committee for a couple more days. And I'm here today. I'm incredibly honored, incredibly excited to be here today with Dr. Gregory Poland. Hi.
Hi, nice to be here with you.
Thank you so much. I'm going to truncate your incredible bio for time, but people can look you up. Dr. Poland, MD, FIDSA, MACP, FRCP of London. Wow. Mary Lowell Leary, Emeritus Professor of Medicine, Distinguished Investigator of the Mayo Clinic, is a physician scientist and the founding and current director of the Mayo Clinic's Vaccine Research Group, a state-of-the-art research group and lab that seeks to understand genetic drivers of viral vaccine response and application of systems biology approaches to the generation of immunity, as well as the development of novel vaccines against emerging pathogens important to public health. The Poland's Lab, wow, it has your name, developed the fields of viral vaccine immunogenetics, the immune response network theory, and the fields of vaccinomics and adversomics. He holds the academic rank of Professor of Medicine and Infectious Diseases and Molecular Pharmacology and Experimental Therapeutics. He is the Distinguished Investigator of the Mayo Clinic and is Editor-in-Chief for the journal Vaccine. He received his medical degree from the Southern Illinois University School of Medicine in Springfield, Illinois, completed his residency and advanced postgraduate work at the University of Minnesota. He has published over 650 professional papers and book chapters and has done a tremendous amount of things that I'm skipping over here in the interest of time. I'm so sorry.
No problem.
Thank you, though. Let's see. Okay, so I'm going to stop now because there's so much to say, but I want to give us a chance to talk about vaccines. I just want to mention that when I Googled you, it came up with you being involved with the Nano Vaccine Institute, and I want people to understand what that is and what your affiliation with them is, because I think people are going to go, Nano, that sounds scary.
Yeah, I mean, it's always good to get our nosology right. So nano simply refers to the size of a particle. So all of our vaccines are macro or micro or nano. It just refers to the size. The Nano Vaccine Institute is something that is housed at Iowa State University, and academics from around the world are a part of that institute in order to share work and ideas with one another.
Okay, good. So that's hopefully a good explanation for people. And also I'm going to ask you to say if you have any conflicts of interest.
Yeah,
Top, please.
I offer consultative advice to all of the vaccine manufacturers, including all of the COVID vaccine manufacturers. All of the funding for my work comes from the CDC and National Institutes of Health, federal government.
Okay, good. Excellent. So we have a lot to talk about. This was a big week because was it the ACIP?
Yes.
That just met on the myocarditis risk. So I'm going to ask you just to start talking about that because it's so important.
Yeah, so first it's important to define what we're talking about with myocarditis. So myopericarditis, so myo refers to the heart muscle. The pericardium, easiest way to think about it is it looks like a piece of saran wrap encasing the heart. All of us have heart muscle and a covering of that heart. Where there's inflammation, we call it itis, so myocarditis or pericarditis. That's extremely common with viral infections. So one thing that's really important in all that we'll likely talk about today, the choice is not between vaccine and nothing. The choice is between vaccine and COVID. I want to make that point really strongly. With a virus that has this kind of transmissibility, if you are not immune to it, you will eventually get infected unless you happen to be in some kind of bubble where everybody except you is immunized. It's a key point, and that leads to a second key point, that people who are unimmunized are now entering into the most dangerous phase of the pandemic. And the reason for that is the variants that maybe we'll have time to talk about later.
We have to. I want to end with that. Do we know what percentage of kids with COVID get myocarditis? Because I think it's not a fair comparison. That's not the only risk of COVID, but do we have any information on that?
I'm sure that there is information on that. I don't know that right off the top of my head, but what I will share with you, and I'm just going to bring it up here, is some of the information where they were able to distinguish, because it's really important to understand background rates. The fact that something happens in association with another thing doesn't mean causality. It means, what's the background rate, and are we seeing a rate higher than background rate? So let's just look at the predicted number of COVID cases prevented versus myocarditis for every million doses of vaccine we give to children 12 to 17 years old, okay, adolescents really. I'm in the presence of a pediatrician, so I better get my words right here. So what happens over 120 days? We look today and we look forward 120 days. For females 12 to 17 years old, if we give them the vaccine, we prevent 8,500 COVID infections, which, as you said, has its own set of risks. We prevent 183 hospitalizations. We prevent 38 ICU admissions, and we prevent 1 death. The cost of that appears to be about 8 to 10 excess myocarditis cases. That sounds scary. When you look at post-vaccination myopericarditis, that means somebody has a symptom. We do tests and say there's some inflammation. Usually a day later, they're out of the hospital and it has resolved. What do we treat them with? Something like Motrin. That's all. Now, occasionally you can see a very severe myocarditis case, but that has not been observed with the vaccine. What about in males 12 to 17? Well, we prevent 5,700 COVID cases. We prevent 215 hospitalizations. We prevent 71 ICU admissions, and we prevent 2 deaths at a higher cost of myopericarditis, up to 69 cases. So you're balancing, and I'm just trying to illustrate that there is no risk-free choice. People need to understand that. It is horribly naive to think that there's a risk-free choice. It's the risk of hospitalization, of ICU admission, of permanent or at least long-lasting sequelae, and the risk of death versus an almost infinitesimally small risk of myocarditis that in the vast majority of cases will spontaneously resolve. That's the data as we know it and understand it today.
You know, I think that we also have to put in perspective that we are looking for this so intensely. As a pediatrician, I see patients with chest pain all the time. I think prior to this, we were probably missing a good deal.
Oh, no question. No question about it. In fact, just to further put the risks into perspective. So in males, we're talking about a risk of about 0.003%. Okay.
I'm sorry, but I've heard the rate quoted from a study. I don't remember what journal it was in, of 2.3% of athletes that were tested after COVID had been found to have signs of myocarditis.
Yes. That's about right. I just don't know the rates in younger kids. In part because up until now, younger kids really have not been hospitalized very often. That's changing, but looking back over the past year. So let's just look at males, the risk of 1 in, let's say, 32,000 or so. Well, the risk of your house burning down is 1 in 3,000. The risk that you'll die over your lifetime in a car accident, 1 out of 107. There are risks to everything we do. And the question, what wise people do, is they say, what's the risk if I do nothing? What's the risk if I do something? And what's the benefit of that doing something? That's the only wise way to make decisions.
Right. I mean, I think one of the problems is there's been a lot of misinformation that makes it sound like children go scot-free from COVID.
Yeah, and that's just not the case. In fact, if we just look at, this is from January to April of this year, what are the data in regards to 12 to 17-year-olds, okay, getting COVID? So about 2.1 out of 100,000 people that age were getting hospitalized. That's a rate 3 times higher than influenza. Now, 12 times lower than adults, but it's not zero. 1/3 of them required ICU care. 5% needed a mechanical ventilator. Fortunately, none died. A number of them are left with long-term, what's been called long-haul COVID, with persistent symptoms. So again, you don't get to choose your risk. Do you get COVID and all that, long list of complications, or the rare chance of myopericarditis found only because we're looking for it, you'd never know you had it otherwise, resolves in a few days, requires no treatment? Which one do you want?
Right. And I think it's important to stress the point that it's only a tiny, tiny percentage of those myocarditis cases who are seriously ill.
Yes.
We're looking so carefully.
And you do have to be careful. So viral myopericarditis from influenza, from COVID infection, much higher risks of complicated disease. Post-vaccination myocarditis is an extraordinarily mild, transient, and self-resolving condition. That risk we didn't talk about females. I'd looked up the risk in females. It's about 1 in 200,000.
Right, it's very rare.
Okay, so the risks of getting infected and of the complications of COVID are like skyscrapers compared to the height of a penny, which represents the risk of myopericarditis.
Right, I'm going to throw it out there though, because this is not how people think.
Right, I know. Well, marketers and people who peddle misinformation and disinformation, they depend on the fact that people cannot manipulate probability and statistics very well. That's why marketers even do things, and it's kind of silly. I don't know what the cost is in New York City, but in the Midwest, gas is $2.89 and 99/100 cents. Well, that's stupid. It's functionally $2.90.
Right.
But you think that it's lower because they list it. What other price do you pay for an everyday item that's listed like that?
Right, it's $19.99, not $20. But it's more than that though, because people look at something that they get from a vaccine with a different level of concern than they would from something that happens to them naturally.
So this is a really important point you bring up, Dr. Minkin. It is what psychologists have noted between acts of omission and acts of commission. And when I counsel parents and patients, you readily see it. I'll walk in and a parent will say, well, if I give this vaccine to my child and something happens, the act of commission, I could never forgive myself. And I scratch my head saying that doesn't make any sense. I go into the next room and the parent says, of course I want the vaccine. If I didn't give it to my child and they got this disease and died, the act of omission, I could never forgive myself. And I scratch my head. I mean, the same day, the same community, two parents in the same cultural environment, thinking two very different ways and not thinking probabilistically. And that's what goofs humans up.
Right. It's so true. And that's why we are trying to have as honest and a transparent conversation about risks and benefits rather than saying, hey, the COVID vaccine, it's safe for everybody all the time. Step right up. We're not. It's really important.
Let me be very clear. As a vaccinologist for over 40 years, there is no such thing as a 100% effective vaccine, and there is no such thing as a 100% safe vaccine. By the way, that's true for every single man-made item, right? If I wanted, like some of the people peddling misinformation, if I wanted to scare you, I would tell you, do you know what the risks of drinking water out of your faucet are? In fact, there are bacteria that now coat these plastic pipes that are making people sick. Well, you have to say, but at what risk? And if I didn't drink water that comes to me through my pipes, what would I drink? Bottled water? That has another set of risks. Unfiltered water? That has another set of risks. So you got to be wise and say, what is the absolute risk? What's the relative risk? And how does that compare the risks and benefits of intervening or not intervening?
Right. And that's why it's so important to get good information. I'm putting together something from our organization, and I'm putting Mayo Clinic out there. I'm putting a plug for the Mayo Clinic, has an amazing website. So does Children's Hospital of Philadelphia.
Yeah.
So does Johns Hopkins. So there's really good places to get your information, even if you don't trust something that says.
That's a good point. I have a lot of conversations with people, and one person had asked me about the vaccine, and she, here I am, I've spent 40 years studying this. And she said to me, well, that's what you say, but my neighbor says. And I said to her, that's a very interesting comment, because I was talking to my grocery store clerk about what kind of mechanical operation should I do on my electronic Honda transmission. And she said, well, what would the grocery clerk know about? And she stopped herself and realized,
right, but the
go
truth
to
is
credible sites.
Right, but the truth is that a lot of people are even more now than ever distrusting.
Yes.
Now, when it's understandable, everything's been so politicized.
Yes.
And I know from JOMA, we're trying so hard to have nuanced conversations and not be mocking and not be, strident, just as honest and calm.
Yeah.
Right?
Well, and that's why I think really I would say to people, don't just go to Mayo website, go to any medical center's website, and you will see basically the same statistics, the same recommendations, because they're based on science. So we can make decisions based on fear or misinformation. That hurts people.
Right.
That really hurts people. And you have to make it based on the data that you do have at the time.
Right. I want to bring up some other things, but before I forget, I want to mention that a lot of people make their decisions on what they see.
Mm-hmm.
And, you've mentioned, we're going to get to it later. I've had people say, well, my kids, had COVID and they were fine back in March. And so before we started, I want you to get a chance to say it, that this is not your mother's COVID.
Well, and they may well be right. The original virus that circulated, and let me just back up and say, the danger here is that people will look backwards at what we've learned and assume that that's the way the world will be going forward, and that is wrong. The virus is changing and has changed tremendously. So the original virus that circulated tended to not infect children in particular, and they tended not to get very sick. There were some exceptions with Miss C, for example. That is not true of the Delta and of the Gamma variants. The Delta variant is essentially 100% more transmissible than the original virus. In children, the viral loads of that virus in their body are fourfold and more higher than with the original virus. That's why up until just recently, when case levels fell, 25% of our hospitalizations in the US due to COVID were now in children and adolescents, because so many adults have been immunized. So what will increasingly happen is that if your child is unvaccinated, COVID will find that child.
Mhm.
I mean, don't be naive and think it won't happen. About probably the official numbers are about 1 out of 9 Americans has been infected. Well, it's higher than that. 1 out of every 530 Americans is now dead of a disease we know how to prevent. So please, I plead with people, don't make the mistake of listening to people who have no training in science and medicine, who have no credibility nationally and internationally in speaking to this topic. We have seen too many, far too many people get sick, die, have their lives permanently altered of a virus we can prevent.
Right, who does affect children. I keep saying it because I'm a pediatrician and I've seen it myself. I saw the phase. I'm in New York and we were hit really hard and the kids were not. And it was awesome. And then, we came to the second wave and we started seeing more kids get sick, and we did see the MIS-C. We saw a lot of that in New York. The multi-system inflammatory syndrome. So that
Yes.
should not be underestimated. And who knows? We don't know yet about the Delta variant, so-called Indian. I know they've renamed them. Variant, and there's others. I wish they had picked hurricane names instead of Greek
Yeah.
letter.
And if listeners haven't heard of it, it will come out this evening. But now we're starting to see circulation of what's being called the Delta Plus variant. So this virus will continue to mutate. Every time it infects somebody, it has the opportunity to mutate. And we get worse and worse variants eventually out of that. So that's why I say we are entering a phase this summer and fall where people who are unvaccinated are at the highest risk they've ever been at.
That's actually really scary. And I know people are going to say, but what about my younger children?
So everybody who's eligible to get vaccinated, you just like, and this is a concept borrowed from pediatricians, you cocoon them. The people around them get vaccinated, and where that child will be exposed to others who are unvaccinated, they wear a mask. And children have shown and accept it readily. They accept it better than adults.
They really do.
A proper mask worn properly is very effective against these viruses.
Yeah, but see, again, back to that, misinformation, it's really been very politicized. Unfortunately, masks don't work. You're torturing your kids. There's whole movements to stop masking their children. And again, I can attest how well kids do with it, but they do better with it when the parents are supportive, and they do less well with it
Of course.
when the parents are not. And just people should not be underestimating that for children, especially even if you have 12 to 17-year-old that you're not vaccinating. And then you're starting getting into all the side effects. What's the word that I want? Not specific effects of not vaccinating, meaning that your child may be kept out of school more, schools may be closed. I mean, there's so many other things. The lockdowns were horrific. We don't want to go back there again. So
well, this relates to another psychological concept called belief-dependent realism. People come up with a belief, often social and peer pressure around them. They come up with a belief, and no data changes that belief. And that's a very, very sad state to be in, because you will make bad decisions for you and your family if that's how you think.
Right. I mean, when we, give talks, make podcasts, whatever, our information is for people who are looking for information, not who've made up their minds.
Yeah.
Already, you can't change the minds of people who actually, Dr. Michael Osterholm, I'm a big fan of Dr. Michael Osterholm and his podcast from CIDRAP.
Yeah.
And he divides it into vaccine acceptors, vaccine hesitant, and vaccine hostile. If you're vaccine hostile, you've made up your mind already.
I can't tell you the number of patients. In fact, you may have just seen the headlines. The only people dying of COVID now, with rare exception, are the unvaccinated.
Right.
We've made the diagnosis of COVID in somebody we've admitted to the hospital, and they're angry at us saying it can't be COVID. COVID is just the flu.
COVID is
and
over.
They go on to die, as I've often said, not of the virus, but they died of ignorance.
I'm going back a little bit because I'm remembering, I want to challenge you because I'm hearing so many different things. When they talk about the data for the children, a lot of people are saying they didn't get hospitalized because they had COVID. They got hospitalized for something else with COVID.
Well, I mean,
That's what they're saying.
I've seen this with adults too. It's a very circular argument. That
Mm.
child was not in the hospital, got COVID, developed a complication. Maybe it's pneumonia, but it was caused by COVID.
No, some
And
of these
so,
children, I'm sorry, I didn't interrupt you, but some of these children are being hospitalized for another condition and then they got tested on admission. So I
yeah.
don't think all of those
So
numbers.
some of them will be asymptomatic or mild, but
Mhm.
some of them, COVID will expose an underlying condition. In other words, let me give you an example in adults. We see adults who have no idea that they have heart disease. They get COVID and they're admitted with, quote, congestive heart failure. Well, they were never in congestive heart failure before. What they had was decreased left ventricular ejection fractions that they had learned to live with.
Right.
And now you add another insult on top of that, and they can't compensate for it.
Right. And you have to keep that in mind too when they talk about the VAERS reports, because a lot of people are focusing on the VAERS reports. There are so many deaths in the VAERS reports after the vaccine.
So you have to understand the VAERS system. It's a passive reporting system,
Mhm.
and you're very right to be kind of frustrated with that, because people look at that who are not scientists, who do not understand it, and they draw fundamentally wrong conclusions. So what will happen is anybody can report a side effect, and they should. If they
Right. They
believe a
should.
side effect, they should.
Absolutely.
So what you find is you take symptom X, okay, and a bunch of people will have reported it. You actually go into the medical record and you find out they had symptom X the 2 weeks before they got the vaccine. So you have to weed all of those out. And then you have to say, what's the background rate? And is this rate we're seeing reported greater or lower than that background rate? And that gives you a hypothesis for causality that you then have to go and prove or disprove.
Right. And I always say that we also have, because one of the other criticisms I've heard it all is that it's underreported. And I have to say, first of all, for COVID vaccine, it's not.
Yeah. Well,
It's not. We're all looking this together and we're all scrutinizing it. And the same vaccine is given to the physicians and their family, like my whole family is vaccinated. It's not like there's a separate hidden stash of the special vaccines that are better and safer.
well, that's what interests me. If you look nationwide, I think it's 98% of physicians, when offered the vaccine, have received it. So you have to ask yourself, do I know something physicians don't know? Tens of hundreds of thousands of physicians have taken the vaccine. Are they all wrong? And you're right because you possess some special knowledge?
Right. And it goes back to, politics and misinformation. And I'm going to go back to hydroxychloroquine and ivermectin, because I've heard so many people saying, not so many people, loud people, I'm sorry, loud voices saying, why take a vaccine? It's not 100% safe, which we agree it's not 100%, right? Nothing's 100% in life. When we have 100% safe and effective cure, it's hydroxychloroquine / ivermectin / vitamins.
Yeah.
I'm
Well,
saying
of
this with all
course,
seriousness because people really believe this, and it's important to,
yeah.
I think it's important to
Well,
address it too.
so the interesting thing is that a lot of people's vaccine hesitancy has nothing, and rejection has nothing to do with the current vaccine. I wrote a review article in the New England Journal back in 2011. Every vaccine introduced into the US since the 18th century has been attended by the same concerns and questions. And what's interesting is that the anti-vaccine people reject science as a way of knowing. And yet, when they argue, they use pseudoscience to support. So they borrow intellectual capital from the scientific method that they reject. It's a bizarre thing.
Right,
So
but
you'll
yeah,
hear
I'm
them
sorry.
say, well, hydroxychloroquine is 100% safe. No, it isn't. What book are you reading? Nobody, no physician would endorse the statement that hydroxychloroquine is 100% safe. It certainly is not. What we can say is, for science problems, not moral problems. For science problems, the scientific method is the best way of knowing. And the science that has been done shows no benefit from hydroxychloroquine, no benefit from ivermectin, no benefit from vitamins, no benefit for all of these things that have been proposed, and evidences of harm. So why would somebody, latch onto that and refuse to let the science change their mind? What if we did that as scientists and physicians?
So I think that just like it's not your mother's COVID anymore, it's not the same world anymore. It's not simply science versus pseudoscience. There is a number of physicians out there with tremendous credentials that sound super, super convincing, that are doing tons of what sounds like legitimate science. It is not pseudoscience per se.
Well, I want to caution.
I want to be very clear about this because it's so subtle compared to what we used to see.
I think you have to be very careful about who those individuals are. They are not immunologists. They are not virologists. They are not infectious disease specialists. These are people, and physicians are perhaps equally as prone to the same psychological missteps that all humans are.
We're human too.
And that's why in science we have something called peer review. We subject our knowledge to rigorous, double-blind, placebo-controlled trials whose results are scrutinized by other scientists, by FDA, by whoever has funded the science. So, let's hold ourselves to the same very high level, else we harm people.
Right. And so what's happening is that a number of these studies are coming out before pre-review and the preprint. We've never had this before, but because of the pandemic, and they'll argue we can't do randomized double-blind placebo-controlled studies because it's a pandemic, which, in the beginning, I remember in New York, and my son was a resident, they were throwing everything at COVID that they could, hydroxychloroquine, everything, and just looking to see what would stick. We didn't have a vaccine.
Right.
I think it's important to talk about what's called clinical equipoise at this point.
Yeah. Well, the difference now compared to the scenario that you're describing is we do have the results of randomized clinical trials. We do know in the United States over 300 million doses of this vaccine have been given. We do have a very good handle on the safety of it. The issues that we still are looking for are so rare that they're hard to even find. Now, for any of your listeners who have ever taken a drug, for example, a prescription, they have never been studied with this degree of scrutiny. There's been almost nothing given 300 million times inside of a year where we could study it. So, you have to simply, the only thing I can say is for individuals that refuse to believe science, then you have to come up with a better way of knowing scientific truth.
Right. And I mentioned clinical equipoise because we didn't define it. That the concept that, for example, you could no longer do a randomized double-blind placebo-controlled study of ivermectin versus the vaccine.
Right.
You couldn't do that.
No, because it would be unethical.
Right. Because we know the vaccine works.
Right.
So in terms of hydroxychloroquine and ivermectin, I know at least for ivermectin, I think that hydroxychloroquine has already been studied to the point of just not in double blind, very good studies, although I'm telling you that in the vaccine hostile world, they will say, but you didn't use zinc, but you didn't do this. And by the way, once you're doing it as an outpatient, they're not incorrect when they say most people with COVID do well.
Yes, well, that is true, but let's define what that means.
Right, but the point that I'm making is that if you're taking a population that primarily does well, like it's contradictory. On the one hand, they say, well, 99% of people survive COVID. And then on the other hand, they say, well, we have a 99+% survival rate with ivermectin. My point is that if you're going to be studying it in a low risk population and an outpatient basis, you need huge trials.
You can't do it. You can't do it and be scientifically valid.
Right. And there are
Which
scientific
also,
studies.
which also tells you that any possible benefit is too low to be of value.
Right. Well, that's the thing is you think you would see a signal.
Yeah.
Right. And what I understand about ivermectin, by the way, is that when they do studies on it in vitro, they're using very high doses that you cannot do in real life. So it's not comparable, but they're still studying it, by the way. So for people who say
Yeah.
they're ruling it out, there are studies of ivermectin ongoing. I presume that at least some of them are randomized, double-blind controlled, but the peer, not peer-reviewed preprints are coming out with meta-analyses with many different studies in them. And by the way, the concept of a meta-analysis, where you're putting a lot of different studies together and you're saying, I see a benefit, you better make sure that all of those going in are good, right? There's a garbage in, garbage out concept of you can't take a bunch of studies and at least some of them are not good. You have to analyze them.
Yeah, it has to be done properly. And again, all that does is provide a hypothesis. And it's not true that we can't, in some cases, do randomized double-blind controlled trials. Countries, for example, where there are no other alternatives and vaccine isn't widely available. That's where some of these studies have been done. So the irony of it, of course, is to take a drug like that has not been well studied for this, propose it based on in vitro studies at the same time that soon we will actually have valid antivirals come out that people will reject.
Is it big pharma?
Yes.
Because I know that they are studying antivirals. And we do have medication, to be fair. We do have steroids. We do have some monoclonal antibodies.
And cytokine inhibitors, yes.
Yeah, but compared to prevention, they always say an ounce of prevention is worth a pound of cure. And it's so true here, putting aside the fact that if you get COVID, you could be transmitting it to other people, right?
Absolutely.
Like your grandma.
Absolutely. Now, you raise a point that I find interesting. Reporters that I talk to are almost shocked by it because it is not a part of the American psyche. And let me just say it bluntly. We are a narcissistic culture. What you hear people say is, well, is this going to benefit me? Other cultures are we cultures. So I get a vaccine not only to benefit me, but my family, my place of worship, my school, my workplace. We do it as a community. And unfortunately, what you're going to see, mark my words, this is one of the few things I will be dogmatic about. You are going to see the emergence of two different populations, a population of vaccinated who maintain their health and well-being, and a population of people who refuse the vaccine, who will die out of proportion, be infected, and have long-term side effects that will significantly affect the quality of their life. So you often hear people say, well, my next door neighbor who's 30 years old and healthy got COVID and it was no big deal. We are very suspicious that a number of those people have had subclinical organ damage that they won't realize because they have such a capacity right now until they're older or have another medical condition. In other words, where they have subclinical myocardial scarring or pulmonary scarring. Men that get COVID, we see profound abnormalities in their semen and their ability to father children. So we're going to see consequences of this that go beyond, well, he didn't get hospitalized and die.
Right. That's another thing that makes me very frustrated when they say, what's the death rate? The death rate's what, 0.5% or 1% or whatever it is, 99%.
Well, it depends on who you're talking about.
Exactly.
In nursing home patients, it might be 15%. In diabetics who are obese with kidney disease, we might be talking 10 to 12% or more. People with lung disease and asthma, high rates of fatality. So it's not just you, it's everybody we're talking about, everybody that you came across in the course of your day. And it's the long-term sequelae of that disease.
Right. I also want to point out, you mentioned sperm count, and there's been a study of sperm count after the vaccine. It was an interesting study, and it
Yeah.
actually showed it was better. I don't know if it's meaningful, but it definitely wasn't worse.
Yeah, it was a small study out of the
Yeah.
University of Miami, and they showed statistically significant increases in
Right.
sperm count and semen quality. It's hard to imagine how that would happen.
Right.
That might be, a statistical aberration. But the important point is it did not demonstrate any defect or
Right.
harm.
Right. Which is very reassuring because people have all these fertility concerns that we're not going to discuss because we've done it over and over. Please listen to all of our other webinars and town halls and podcasts. Um, I I think I'm going to stop here, even though there's always more to. Well, no, I'm going to have a little more of your time.
Sure.
Okay, so the one thing we didn't talk about that I wanted to talk about was vaccinating people after COVID. I think it's really important. There's a lot of talk about natural infection is better and why would I get the vaccine after I had COVID? And I think we're going to leave aside vaccinating children and teens after COVID because that's a different group. And I'm going to just leave that be. We're just not going to discuss it. Let's just discuss 18 and up because every group has a
Okay.
different risk benefit ratio. I think let's just stay with
Right.
18 and up for now and make it
So
simple.
I'm gonna necessarily, for any of the listeners that are physicians or scientists, I'm simplifying here, but let's just say with the virus, there are 20 some proteins. So when you get infected, your body makes a not very deep but very broad immune response against all of those proteins. In other words, the immune system is distracted into making antibody against all the proteins of that virus. When you get a vaccine, you're making an extraordinarily deep but narrow immune response against one protein in the virus. Turns out that it's the critical one necessary to bind to cells. So think of that S or spike protein like a key that looks for a lock to open and get into your cells and infect you. So you get a much higher immune response against the vaccine than you generally do against the disease. So why would we come up with the idea of immunizing people against who have previously gotten infection? Number one, we see breakthrough disease. And the reason we see and by the way, those breakthrough cases occur a mean of only 116 days after they got infected. That's pretty stunning, but it fits with what we know about seasonal coronaviruses, where you keep becoming susceptible. So the idea is give people who have recovered from, we usually wait about 90 days, who have recovered from COVID, at least one dose and ideally 2 doses of vaccine, but at least 1 dose in the post-COVID patient. I'm not talking about everybody, to boost and deepen, if you will, that immune response against the spike protein. And those data are bearing up that that is indeed a good strategy and a wise strategy.
Right. And I think, because I try to be, transparent here. 2 things I'm thinking of. I'm sorry. One is, well, is the vaccine so perfect? Is it 100%
No,
in terms of preventing infection, especially with the new variants?
no, it's not.
No.
It's not. And, I'd be the first to admit it. I just found some of the data related to this, and let me talk to you about that. Go on with your next question while I find this, because I do want to share it.
Because like I said, it's so important to be transparent here. It's a very fair question. What makes you think that your vaccine immunity is better? And you gave one way that it is actually superior in terms of long lasting, in terms of how it affects the variant. These are all very good questions. The way I think about it is, for someone who has had COVID already, you're getting, I think it's like 10 times a better immune response with one vaccine.
Oh yeah, yeah. Well, here's the problem though. Against these variants, a single dose of the mRNA vaccine only offers 33% protection against the Delta variant. But when you get 2 doses, you're back up in the 90 percentile.
Right. That's for people who are COVID, who never had COVID, but is that true
Right.
for people who have? Do we know?
No, so people who have had COVID and we get at least one dose of vaccine into them, they tend to do very well if they have a otherwise healthy underlying immune system, right?
Right.
So the solid organ transplant patients, we actually have to give them more like 3 doses of vaccine.
Oh, wow. So
All
for,
right, so here's the one of the largest reinfection studies that has been done. Over 9,000 patients across 62 centers in the U.S. This was done from December of 2019 to November of 2020. Results might be different now that we have Delta variant, but this was then. So they had, in order to prove reinfection, they had to have 2 separate tests to prove it. Reinfection occurred in 0.7%, a mean of 116 days afterwards. When you look at breakthrough infection in people who have been vaccinated, far lower than that. It does happen because not everybody's immune system is healthy enough to drive a protective immune response.
I think it's very confusing with the numbers, though. And I think that it was also confusing with the messaging when they said, oh, only a tiny percentage of the people who had the COVID vaccines got COVID. And Dr. Michael Osterholm talks about this. People should tune into his podcast to learn more about that. It's a little confusing because, and I think it's also confusing to people because they're going to hear 0.7 and say, well, I have a 99.3% of not getting reinfected. And that's not what that number means. I think maybe it's important to clarify what that number means. It's not your chance of getting reinfected.
No, that's an observed rate of detectable reinfection in people who have previously had it. So what's confusing is there's an absolute risk, there's a relative risk. And when you look at vaccine efficacy, for example, when you read the headline, Pfizer vaccine, 95% effective, that was in a clinical trial of selected people. It will be lower in some populations, higher in other populations. The young, healthy individual, they're probably going to be up at 97%. The solid organ transplant, 40%. The 85-year-old with a lot of comorbidities, maybe you're at 80%. But what those numbers mean is an 80% reduction in the risk of infection compared to people who did not get vaccine.
Right.
So again, it's one of those issues of people realize, this gets to what's called the democratization of expertise. People with no training and no expertise believe they know.
Right.
And then they try to fit the headlines into their belief system. That's not how science works. The way we work in science is there's a hypothesis. We design as rigorous a study as we know, and then we accept or reject the hypothesis we went in with. And then we keep modifying that as new data comes out. The public has to learn that that's how science works. So we may know, somebody said to me, well, this is like one day eggs are good for you, one day eggs are bad for you. No, that's how you're understanding the headlines. The studies are actually different and they're talking about different aspects. But if you think you know and you don't know, you readily misinterpret the headlines and you come up with wrong conclusions. And then you become fixed in those conclusions. And that's a very dangerous place to be.
Right. And that's why we're trying so hard to just be really straight about it, give the information. So back to people who had COVID, because I'm still on this. I'm almost done though. A lot of people are saying, but antibodies, I have antibodies. And I feel like we've done this a number of times, but I don't think it's okay to leave it out in this talk. I know in my family, my son had COVID and I never wanted his antibodies measured. And yes, I got him his COVID vaccine after. Full disclosure. What was I going to say?
So you were asking about maybe level of antibody. Part
Yes.
of the
So I did
problem
measure
with
it because I don't think that we can use these antibody measurements to say how well a person is going to be able to fight off another infection.
yeah, what you're really referring to is a concept in vaccinology called correlates of protection.
Mhm.
So in other words, what blood marker could we measure to say that somebody's protected or not protected? We use that in vaccinology all the time. We're getting closer and closer. And today, on one of the preprint servers, is one of the first studies proposing such a correlate, which only worked for symptomatic COVID infection, didn't work for asymptomatic, for some really important but nuanced scientific reasons. So we are getting closer, and the time will come when we will be able to measure that in order to perhaps determine when subgroups of people might need booster doses.
Mm-hmm. Right. But for now, when people are measuring their antibodies, they're not necessarily getting information, right? Like they may be getting different
Well,
kinds of antibodies mixed in.
yeah, so what's key, and this might be going deeper into the clinical practice than you want to, but the nature of the patients that I see at Mayo Clinic, some of them have very unusual medical conditions that we're trying to manage. So let's take a solid organ transplant patient. Mm-hmm. If I'm able, and by the way, soon we're going to have cellular tests, T-cell tests, but if I measure a specific kind of antibody, an anti-S IgG RBD antibody, and it's in the thousands, I can pretty confidently say, as best we know, you're protected right now. Right. If that antibody comes back and it's 100, I don't know that. The problem is with every measure in between. We just don't have, and again, I want to be very transparent here. We do not yet know that number that is a cutoff for who's protected and who isn't.
Right, right. And that's why we have to be so careful, when you hear things in the news, a study has come out and it has shown that if you had COVID, you're not likely to get, reinfected, and therefore you should not get the COVID vaccine. There was a study.
Yeah. I mean, it's things like when people tell me that, I look at them and say, you know what? I've got a 90-year-old patient who has smoked for 75 years. And they ponder that for a moment and they say, yeah, there'll always be exceptions, but what does the data for the population show? Now you're thinking like a wise person.
Right. Right. This particular study was of healthcare professionals who were probably wearing a lot of protective equipment and living a different kind of life, and they should not have drawn that conclusion. They can give you the data, but once they draw that conclusion. So I have to thank you so much. You've been really open and transparent, and you spoke really slowly. That was good for people.
Midwesterner.
I know. Thank you. I hope we can do this again someday.
Yes,
I really appreciate it. Thank you.
Thank you, and Shabbat Shalom.
Shabbat Shalom.